Hi dear postgraduate students, I am Colonel Pradeep Pendyala, Professor of Anesthesiology at ASRAM Medical College, Eluru City of Andhra Pradesh, India. This is my first sincere attempt to make a video which you would like to watch in your spare time, and I assure you it will be very useful for your preparation for your postgraduate MD Anesthesia, viva as well as theory. I assure you that. Now today I'll be discussing something about bronchiectasis, a patient with bronchiectasis and how the anesthesia and anesthetic management is involved. I'm sure you know what is bronchiectasis. It's an irreversible chronic condition where the airways in the lungs become damaged and abnormally widened from recurring inflammation or infection. So far so good, but what is required that you should be prepared for some unusual question from the external examiner. The internal examiner will be very sympathetic with you obviously, but the external may be not sparing you in case you don't answer properly and the basics. He would try to judge you whether you know the basic concepts of anesthesia or not, whether you would make a safe anesthetist or not, whether you understand the pathophysiology of the discussion of the particular case, long or short case. Either things can happen. The short case can become long case and long case can be presented to you as a short case. So let's come back to the topic of bronchiectasis has been given to you as a case with, and you are likely to be asked different questions. So the question, very simple question which might not be there anywhere or you might not have thought of that it should be asked. The examiner might ask you, what is the difference between bronchiectasis and COPD? You become flat, you fall flat on your face because you are not prepared for it. The question is, what is the difference between bronchiectasis and COPD cases? And the answer should be, bronchiectasis is caused by consistent inflammation or infection in the lungs, whereas most of the COPD conditions result from exposure to smoking, allergies or pollutions. So that's a very, very simple question, but you may be clean bowled by the simple question. Well, in the discussion, invariably you'll be stuck when you'll be talking about predisposing factors of bronchiectasis. I'm sure you will be telling predisposing factors include immunosuppression, disorders of ciliary motility such as carcinogenesis syndrome, and there you'll be stumped again. The examiner, the external preferably, he would ask you, what is carcinogenesis syndrome? Explain. You might not be knowing except a very little thing about triad of carcinogenesis syndrome. You might or may not be knowing even that. Well, you have to tell carcinogenesis syndrome is a rare autosomal recessive genetic ciliary disorder comprising of triad of situs inversus, chronic sinusitis and bronchiectasis. The basic problem in carcinogenesis syndrome lies with defective movement of cilia. If you know and understand that, everything is solved, leading to recurrent chest infections, ear, nose, throat symptoms and infertility, especially in women. Obviously because of lack of adequate ciliary movements in the uterus. Well, and when you are presenting that case to the examiner, all this clinical findings, all those things, and you will be invariably telling about the symptoms of the patient as he or she having persistent or recurrent productive cough, purulent sputum, frequent respiratory tract infection, hemoptysis, and sometimes the patient may have or may not have weight loss and fatigue. So far so good. You cannot be judged in this, but the moment you tell about signs of bronchiectasis of the patient, you will be invariably telling about the crepitations, which are V's, and bronchial breath sound. And next, you would be saying, clubbing has been found in the patient. There, the question would be, gentlemen, doctor, what do you understand by clubbing? And how does it occur? Again, you are stumped. These are the things which happens in orals and viva. You prepare for big things, very latest, recent advances, all those things, and you will be stumped when you will be asked simple question, doctor, how do you understand, what do you understand by this, what is that? Clubbing. And how do you explain it? Then you have to take a deep breath, smile at the examiner, and start answering it slowly and confidently. Okay? Not fidgeting with your thumbs or fingers or snapping your fingers or something. Don't feel nervous. Smile. In case you don't know altogether, say, I don't know, sir. Boldly. And it should be audible. Okay? And not murmuring business. Never try to murmur. And these days during this pandemic, you will be given a mic also, microphone, where you keep it closer to your mouth and speak it loudly and clearly. So that the examiner gets a feeling that you are confident and your answering is very clear and understandable. Don't keep mic 2 feet away from your mouth and start mumbling something. That gives very bad impression. Mic is supposed to be used and it is supposed to be your voice to be amplified so that from a distance the examiner, if God forbid even next year the pandemic continues and the examiner is sitting from a distance of 10 feet distance wearing a mask and all those things, safety gear, he would be able to hear you properly even when you are wearing a mask. So there you have to tell the tips of the fingers, would be seen enlarged and the nails become extremely curved from the front to the back. Clubbed fingers is a symptom of a disease, often of heart or lungs, which cause chronically low blood levels of oxygen. And that is the cause of this formation of clubbing. Incidentally, some of the diseases like malabsorption such as cystic fibrosis or celiac disease can also cause clubbing, sir. Well, if the examiner is little more strict, he may ask you what are the various causes of clubbing besides bronchiectasis. Then you can tell him and make him totally surprised by telling the mnemonic of clubbing. Clubbing has a mnemonic, M-N-E-M-O-N-I-C. C-L-U-B-B-I-N-G. C stands for the reasons, the causes of clubbing are cardiac, subacute infective endocarditis, cyanotic heart disease. L stands for lung abscess and empyema. U stands for ulcerative colitis, biliary cirrhosis. B stands for bronchogenic carcinoma. I, idiopathic, N for not COPD. It's not a COPD, I told you earlier. Bronchiectasis is not a COPD. And G, gastrointestinal, like malabsorption, celiac disease or Crohn's disease. These are the various causes which can cause clubbing. Well, now next, what is the pathophysiology? Very simple, inflammatory changes that can cause dissection of normal structure components of the bronchial wall, replacement by fibrous tissue, abnormal dilation, pooling of the secretion which causes secondary infection. This is the thing which is very simple, but you should be confident. Okay, and what are the investigations you would like to do? I tell basics, sir. I would like to do CTC, see whether there is a raised white blood cell count or not, whether neutrophils are raised or lymphocytes are raised. If lymphocyte has raised, tuberculosis could be there. I would ask for liver function test, chest X-ray, although it is not great of help because I would prefer to have these days computed tomography, CT, thorax, to check the extent of the bronchiectasis and lung abscess, if at all is there. When CT chest is done, CXR is just not required underscore. It measures the diameter of the trachea and bronchi, and that would be helpful to decide the size of the double lumen tube which you would be using, especially in one lung ventilation when you are planning for lobectomy or something. And you would go for ECG, electrocardiogram, and you would find invariably P pulmonale. He would ask you what is P pulmonale. Sir, you would find all R waves in V1. There could be right bundle branch block known as RBBB. Right axis deviation could be there. Right ventricular strain could be there. That would be visible as ST depression in T wave inversion and right sided precordial leads. That means V1 to V3. And I would go for pulmonary function tests, preferably spirometry and diffuse capacity of lung for carbon monoxide. And I would prefer to have arterial blood gas for evidence of any hypoxia or hypercarbia, that means PCO2 high, or if at all there is a raised bicarbonate with a normal pH which suggests coexisting COPD. That's very interesting, isn't it? And I would go for sputum, gram stain of the sputum culture sensitivity, sir, and I would go for 2D echocardiography to measure the pulmonary artery pressure to diagnose any evidence of pulmonary hypertension or not, or if there is any right ventricular hypertrophy or not. Well, and if I want, I would like to invest in HRCT. What is HRCT? High resolution chest computed tomography. That would give me internal diameter of the bronchus if it is larger than the diameter of the accompanying vessel. That is very diagnostic, and the bronchus normally fails to taper in the periphery of the chest. Airway walls thickening is not diagnostic of bronchiectasis. That is it. And sir, I would go for spirometry. What would you see in spirometry? That would be the obviously question followed by this type of discussion. Spirometry shows a reduction in forced expiratory volume in 1 second, that is known as FEV1. Through forced, though in spite of that, FEV1 is reduced, although forced vital capacity is normal. That means FEV1 by FEC ratio is reduced. This suggests moderate obstructive pattern. And I would see if at all there will be post bronchodilator changes, whether there is any improvement in FEV1 or not. That will be very significant, which is normally we have, if it is more than 12% in the improvement after bronchodilators, we have around 200 ml improvement, which will be taken as indicator for good reversibility. So this is the type of questions you would be asked, but don't be disheartened if you are not able to answer many questions. Then you may be asked, what is enumerate the etiology of bronchiectasis? Simple. Infection could be bacterial infection like Haemophilus influenza, Mycobacterium tuberculosis, and immune dysfunction. There may be cystic fibrosis, and there is one thing very important, that is there could be alpha-1 antitrypsin deficiency. That is very remarkable, and I have already mentioned about Cartagenous syndrome, and it could be also accompanied with the rheumatoid arthritis. How would you suspect bronchiectasis? Persistent or intermittent chronic cough with sputum production. There could be hemoptysis, there could be fever, loss of appetite, and many patients, more than 50% patients may have pleuritic chest pain. That should be your answer. So, when can a patient with bronchiectasis be considered fit for surgery? And the answer should be when it is localized unilateral in the lung, and the volume of sputum decreases to less than 40 ml per day, and secretions are no longer purulent, and secretions are not foul smelling. That is the time you can take the patient for surgery. What are the anesthetic considerations in a patient with bronchiectasis? You should always insist of lung isolation, because to protect normal lung, from being soiled with pus from the infected regions. And decortication can be sometimes will have severe blood loss. So you should be prepared for that. And they may ask you, may or may not ask you, so how is the technique of general anesthesia in a case of bronchiectasis? You should always say the same thing which I mentioned. It is important to avoid spillage of pus into the contralateral lung, which can occur during induction of anesthesia. To prevent this, we would always go for something which is administered to these patients where the secretion retaining positions are obtained, so that infected secretions remain in the affected lobes and it doesn't go to the normal lung lobes. In this case, whereas the adequate pre-oxygenation is very necessary and very important when you are using single lumen tube followed by lung isolation by the bronchial blocker. Alternatively, you can use DLT, that is double lumen tube, also for lung separation. But one question is very, very important and you should know that a rapid sequence induction is very important to avoid prolonged positive pressure ventilation, which can again increase chances of spillage. And incidentally, you will have to tell that you in this cricoid pressure may not be of much use, because here there is nothing is aspirating from the stomach or through the esophagus. We have to prevent intrabronchial, intralobar spread of the pus. In that way, cricoid pressure will not be of much use. And during the ventilation, you have to insist that I would prefer to give CPAP to the infected lung to decrease the shunt fraction to prevent hypoxemia. That would really impress the examiner. And what monitors would you like to use for this patient? That is very normal, the usual thing which you use: pulse oximetry, ECG, non-invasive blood pressure monitoring, capnography, urinary catheter, or temperature probe. And if you are very keen, you can use invasive arterial line also, because there could be blood loss also during decortication. So what post-operative management in this patient? You would say that I would prefer the technique of anesthesia as general anesthesia with thoracic epidural anesthesia. That will be very effective for perioperative analgesia, sir. He will be very happy. And you can say I would prefer to give supplemental oxygen if at all required post-operatively, and preferably strictly humidified oxygen I would give, sir. And SpO2 would be definitely very well monitored post-operatively, sir. And he may ask, what are the post-operative complications in this patient? Very simple: empyema, arrhythmia, atelectasis, pneumonia, bronchopleural fistula. That's all. And thanks for patient listening. I'll be coming back with more of such videos. I'm sure you would watch them, you would benefit from them, and please do comment in my on my YouTube or something, or send me a message in my WhatsApp and tell me what are the things I did yet to be covered, and to make it more accessible and easy to understand. Thanks for patient listening. Once again, all the best for your exams. You must pass with flying colors, MD Anaesthesiology. Bye-bye.